Very happy to announce Professor Rachel Batterham from UK to give this talk. Rachel, the floor is yours, please.
Good afternoon or good evening, everybody. I'd like to thank the organising committee for inviting me, and I'd like to thank you all for being here. Now, I'd like a show of hands at the beginning as to who actually knows what person-centred care or person-centred approaches are. Because I have to confess that until I started writing this talk, I don't think I was entirely clear. So who actually has a very clear idea in their head what person-centred care is? So hopefully, by the end, a few more people might know. So here are my disclosures. So over the next 20-25 minutes, I'm going to talk to you about what is person-centred care, why is it important, what it actually involves if we're going to implement it, and then focus on person-centred care for people with overweight and obesity, because that's the thing that we really need to be doing. So what is person-centred care? Well, it is what it says on the tin, but there isn't a precise definition. There's lots of different definitions, but it's basically putting people and families at the centre of the decisions that affect their care and making sure that they're working in partnership with healthcare professionals. So it's changing the focus of a consultation from what's the matter with you to what matters to you. So it's all about what actually matters to the person that you're seeing, and it shifts it from a disease focus to an actual person focus. So it really is about thinking from the patient and the person's perspective and treating them with respect and dignity. And it's also sometimes called patient-centred, family-centred, user-centred, and individualised. So the word person is used to really make it holistic and not to focus it down just on one disease. So we'll often say, oh, the diabetic patient. Well, actually, we need to think about all the other aspects of that person, not just one disease process. And it also, the person aspect takes into account their preferences, their well-being, and also their social and cultural background. So a person-centred care is really about doing things with people rather than to them, which is a real paradigm shift from how medicine was traditionally practiced. And it really is rooted in the universally held principles which are enshrined in international law. As I'm going through these, think about whether your patients with overweight and obesity are afforded these privileges. So human right and dignity, non-discrimination, participation and empowerment, access and equity, partnership of equals. So person-centred care really is about working in partnership. It's not about just giving people what they come in and ask for. It's not about, oh, I want this, oh, yes. That's not working in person-centred care. It's about providing them with the right information and about involving them in every aspect of the care and the services. So planning, developing, monitoring, and ensuring that the care is actually fit for what they want so that it's fit for their purpose. So why? Why do we need to change from the doctor-dominated, this is what's best for you approach to a person-centred approach? Well, it's to do with how disease has changed. So we've gone from infectious diseases being the main burden to being chronic diseases. And not only that, but most patients will have more than one chronic disease. So people are living longer and they've got multiple problems. So it's not just short bouts of care that they need, it's lifelong care. So professional care that a patient will probably have during a year is about 5 hours, if they're lucky, coming to a diabetes clinic or for their COPD. And that means that for the other 8,755 hours of the year, they're actually managing their conditions themselves. So we really need to empower people to manage their health, apart from the 5 hours that they might have seeing a physician. So we really need to shift the balance away from health services that are disease-focused and doctor-focused and more patient-focused. And what's the bigger picture? Well, as you probably all know, the bigger picture is actually universal healthcare for all. And that's one of the key targets of the WHO. And if we're going to do that, then again, we really need to shift how we're delivering care, because we don't have the resources for it to be doctor-focused. It has to be person-focused. And we need to deliver it through an integrated and people-centred lens. Otherwise, we're not going to reach the people who actually won't access healthcare. So it really does need to be designed for people in the right format. So why not patient-centred? Patient-centred, again, is good for people who have diseases. So it's about a holistic approach to health. But we don't want just to treat people who have diseases. We want to encourage health and well-being. So we need prevention. And in order to have prevention, we need to reach people before they're unwell. So in order to do that, it needs to be reaching out to families and people who are well beyond the clinical setting and empowering change to improve their health. So by having a person or a people-centred approach, it means that we're going to get a much better overall improvement in global health. And to do that, we need to educate and empower people to be involved in protecting their own health. So there's a real focus with person-centred approach on health and well-being rather than disease. And this diagram here is the determinants of health. And we have to remember that health is a complex interplay between physical, social, economic, cultural, and environmental factors. And again, so we need a whole systems approach when we're thinking about person-centred health rather than just focusing on the medical aspects of it. So there are many different aspects of person-centred care, and these are just a few of them. But being able to access the appropriate care is absolutely key. And again, think about your patients with overweight and obesity, being able to access care that's appropriate when they need it. We also need to ensure that care and services are joined up, not sort of separated by voids that don't talk to each other. And there needs to be excellent communication about health and information and education to the general population and also to specific disease groups. But then we also need to make sure that the physical environment is suitable for people. Is it safe for them? Is it appropriately sized? Are they comfortable? And we also need to not forget the emotional support that people need to have in addition to just medical support. And we need to involve their family and friends. People don't come in isolation. They live in an environment, and in particular, when we're thinking about overweight and obesity, we really need to think about their family and friends and who they're living with. And also, it changes. So one person's needs are not the same as another. And also, they change with time. So person-centred care needs to be individualised, personalised based on genetics as we go forward. But it also needs to be able to change as their life changes. So it needs to be responsive. So why is it important? Why is person-centred care the latest sort of buzzword? Well, it's all about improving healthcare delivery and improving global health. And the concept is that if we actually give people the power, then it will actually improve quality. And if we put people at the centre of their care, then they will be the people who will really be responsible for driving quality, because they are the people who are living this care, not just delivering it. And hopefully it will mean that people get the care they need. They'll be more active in looking after themselves because they're invested in the care systems. And one of the ultimate aims is actually to reduce the pressure on the health and social services. And there is quite a lot of research looking at the fact that this approach does really reduce how much people use healthcare services people to live a healthier lifestyle, encourages exercise and healthy eating, and also encourages people to be really involved in decisions rather than just being passive and doing what they're told to do. And there's an impact on health outcomes already been proven using this approach, for example, a decrease in blood pressure. And as I've said already, there's evidence that this approach reduces how much people use healthcare services because they can manage their own problems without actually going along and using services. And from the professional perspective, because doctors also like to have some positivity back from their patients, there's, again, evidence to say that this approach actually, doctors enjoy it more because their patients are also more confident and engaged in the whole disease management process. So I'm British. We fortunately have the National Health Service, which this year celebrates its 70th birthday on the 4th of July. And actually, patient-centred care is one of the 7 core principles of the NHS Constitution. And in theory, strengthening the patient voice is also part of the NHS policy, with a move away from the sort of paternalistic approach where healthcare professionals do things to patients to actually being patient-centred. So the Health Foundation, which again is based in the UK, has 4 principles to person-centred health. But round the outside of this is that the person must be treated with dignity, compassion, and respect. So care has to be enabling. What does enabling mean? Well, it means that if you're going to have care that's enabling, you have to have a true partnership between the healthcare professional and the person receiving the care. It can't be a doctor-dominated system. Care has to be coordinated, and it also has to be relevant to the person, so it needs to be personalised. So the WHO, in order to achieve its vision of universal healthcare for all, put together or published a framework for integrated people-centred health services in 2016. So the vision for this is that all people will have equal access to quality health services. And I think that's a vision that we should all sign up for. That the health services that people are going to receive are co-produced in a way that actually meets their life course, which your needs change as you age. But it also needs to respect their preferences because people are very different. And they need to be coordinated, comprehensive, but obviously safe, effective, timely, efficient, and acceptable. So it's all sounding good so far. So in order to do this, they came up with 5 interwoven implementation strategies, which are illustrated here. So you obviously need to engage and empower people, because unless you've actually got people interested and give them the knowledge they need, then you're going to get nowhere. So engaging in empowerment is critical. Then you do need a strong governance and accountability, otherwise you get people doing things that are unregulated. And then we need to reorientate the model of care away from the doctor-dominated, you do this and come back approach, to this is the services that we need, and empowering people to look after their own health. Coordination, again, is absolutely critical, and creating an enabling environment. So this slide here just sort of illustrates conventional care compared to a people-centred care approach. So with conventional care, the focus is on illness and cure, whereas with a people-centred approach, it's on health needs. And there's a very different kind of relationship, whereas conventional care is often very episodic, delivered with acute episodes, whereas people-centred care is an ongoing approach. With conventional care, users are the consumers, whereas with a people-centred approach, then the people are the partners who are managing their own health most of the time in the community that they live in. So there are 5 domains of person-centred care that you need, but critical to all of it is information and education. So unless people understand, then they can't get involved in the rest of the processes. So information and education are critical, But that information and education has to be communicated in the right medium, at the right level, so that people can actually digest it and understand it. Then people need to be involved in decisions. Care needs to be coordinated. And then for people with diseases, there needs to be an active care plan that can then be enacted and followed. So again, there's a public body called National Voices, and this is a quote from their website about person-centred care. And again, from the person's perspective, it means that they can plan their care with people who actually understand them, understand their environments, and really feel that they're in control of their own care and their healthcare problems. One of the biggest problems at the moment is healthcare records. And I have no doubt that as we have improvements in information technology, then this will really also help person-centred care. I'm not quite sure what it's like in all countries, but in the UK, we have a fragmented healthcare system with lots of different electronic healthcare records that don't talk to each other. So a patient will often have multiple sets of records in multiple hospitals, and this is a real problem when you have people with multiple chronic diseases and complex patients, because it often takes you hours to try and piece together what investigations have been done when, and we always go back and start taking the history again. So in an ideal world, we'd have a centralised health record that everybody put the data into, and that would be fine. But the practicalities of doing that using the current data are a problem. So blockchain. Blockchain may have the solution here. So blockchain you may have heard of to do with Bitcoin. So blockchain is going to be sort of the new internet, and it probably actually does potentially hold a lot of benefits for healthcare. And if you have a spare 10, 15 minutes, I urge you to go into YouTube and have a look at blockchain and how that's going to impact upon healthcare. The advantage of blockchain is it's decentralized and also much safer in the way that it's encrypted. So potentially what that would enable to happen is actually for everybody involved in a person-centred care to enter electronic data that everybody else can access. So we need to be mindful of technological advances because they will impact upon person-centred solution. With anything that we do in healthcare, we need to assess it and then improve on it based on the assessment. So traditional healthcare is measured looking at activity, clinical outcomes, and sort of not really focusing particularly on people. Whereas person-centred care really does focus on people, on their sense of well-being, quality of life, but it also does need to look at disease outcomes. So we need to have both in person-centred care. We need that health-related quality of life, but we also need to see what we're doing in terms of impact upon disease. So some of the outcomes, which I'm sure you will have heard of, so health literacy is really important, patient-reported outcome measures or PROMs, something called PAM, which is a patient-activated measure, which is 13 questions which really assess a person's concept of themselves as an active manager of their health and healthcare. So I think PAMs are going to become more prevalent. There's also health education questionnaires, PREMs, and also qualitative approaches, interviews and narratives. So we need different sorts of measures to really see how we're impacting using a person-centred healthcare approach. So what about person-centred healthcare for people with overweight and obesity? So obesity, overweight, chronic condition, disease, linked to multiple other long-term conditions and reduced life expectancy. So based on everything that I've told you already, you would anticipate that actually this would be an area where person-centred care was already being implemented. Well, is it because obesity is a relatively new, inverted commas, disease? Well, actually, I wanted to give you a little bit of history. So Hippocrates, 2,000 years ago, first recognized that obesity was a disease, that those who are constitutionally very fat are more apt to die quickly than those who are thin. And if we look at the Hippocratic corpus, obesity was considered the cause of disease and in extreme death. Well, what if we go more recently? So 1997, the WHO published their first document on preventing and managing the global epidemic of obesity. And in this, they clearly stated that obesity was a disease, a complex, incompletely understood, serious chronic disease that required prevention and management strategies at both the individual and societal level. So again, clearly showing that this would benefit from a person-centered approach. As we know, more than half the global population are now overweight or obese. So again, we've got a serious condition that's very prevalent. Not only that, not only is it affecting adults, we have a serious condition that's prevalent that is actually now really affecting our children, with 41 million children under the age of 5 overweight or obese. And if we look at the rates of obesity, they're increasing exponentially. So again, we've got a serious problem here that would benefit from a family-centered approach, not just a person-centered approach. We also know, as I've said already, that obesity reduces life expectancy. So in terms of the fact that person-centered approaches are really meant to help you when people have got lots of other long-term conditions, if we look at all the diseases that come with obesity, as you know, there are multiple metabolic problems, in particular type 2 diabetes, fatty liver, infertility. There are the mechanical problems of obesity, and there are also the psychological problems. So again, all of these, if you were using a person-centered approach, would really benefit from this topic or manner of management. So do we do this in the UK? So telling you that the NHS has got person-centered approach as one of its 7 core values. We certainly have a large problem with overweight and obesity in the UK. We have 27% of our adults are obese, and the other 36 are overweight. And this weekend, they published in our newspapers that our obesity rates in 11-year-old children have now overtaken America. We have 1 in 5 11-year-old children with obesity compared to 18% in the US. So again, we've got a big problem, but are we using it? So NICE published very comprehensive guidelines in 2014 on the identification, assessment, management of overweight and obesity in children, young people and adults. And this again states that we should be using a person-centered approach to manage people with overweight and obesity. We also have this fantastic tier system, which starts off at the bottom with tier 1, which are public interventions. Then we have multi-component weight management, multidisciplinary teams, and then bariatric surgery. So this is what is supposed to be in place. Excellent guidance, excellent theory of what should be happening. And I do really want to highlight the bariatric surgery because we have a lot of evidence for bariatric surgery. So we know that bariatric surgery for people with severe obesity engenders marked, sustained weight loss for 20 years. We know that it causes marked benefits in terms of the comorbidities that come with severe obesity. In particular, type 2 diabetes goes into remission or is markedly improved. Improved quality of life also prevents lots of other problems with an overall decrease in mortality. So bariatric surgery is a really effective treatment for people with severe obesity, and it also decreases the microvascular complications of type 2 diabetes by 30%. Again, we have fantastic, nice guidance saying that we should be using bariatric surgery for people with obesity and type 2 diabetes. There's then international guidelines, again, stating that this is what we should be doing, and Diabetes UK also say surgery must be used. When we look at what happens, less than 1% of people who are eligible for surgery actually have it. So despite all of our best guidance, our concept of person-centered care, we actually have not at all been delivering on what I've been telling you about. We have poor training of healthcare professionals, lack of a patient voice, poor provision of specialist clinics, poor access to long-term treatment. So recently, an all-party parliamentary group, so this is all the different parties, have looked at what's going on in the UK in terms of the provision of obesity services. And this was published on the 15th of May of this year, looking at what is the current landscape in the UK despite all of our guidance. And it was actually very insightful. So out of the people surveyed, so this was a combination of people with overweight and obesity and healthcare professionals, 88% of people with obesity said that they'd been exposed to stigma and criticised as a direct result of their obesity. 94% of the respondents said that there wasn't enough evidence or not enough knowledge about obesity amongst the public, politicians and other stakeholders. And only 26% of people said that they'd been treated with dignity and respect. So this is a fundamental sort of core value that, and 74% are not actually feeling that they're being treated with dignity and respect. And more scary, given that in the UK, the first point of call is your GP, 42% of people said that they felt too uncomfortable to even speak to their GP about their obesity. Is this just a UK thing? No. So the Awareness, Care and Treatment in Obesity Management Action Study, which was undertaken in the USA, to look at sort of barriers to obesity management and to look at sort of behaviour and insights, also found a very similar problem. So again, if you actually ask people with obesity, 82% of the people who were actually asked considered that the weight was just their own problem and that they couldn't ask anybody else for it. And only 55% had had any formal diagnosis from their healthcare professional. And again, if we go to healthcare professionals, they're not much better either. So obesity, which is a chronic condition that we know has serious complications, then actually how it's being managed in a person-centred approach, then it really isn't. Why? Well, weight bias, stigma, and discrimination are the key three problems that we face if we're ever going to be able to implement a person-centred approach to people with overweight and obesity. So weight bias, which is negative attitudes and views about obesity and people with obesity, which is really propagated by the media. Weight stigma with labelling, stereotyping, damaging identity, really is deeply rooted in society. And then weight-based discrimination with verbal, physical, and subtle and overt actions and expressions, often coming from even healthcare professionals. Again, this is recognised by the WHO that obesity stigma has really adverse health problems and causes health inequalities. And that obesity stigma is a fundamental cause of health inequalities and adds an added burden to the people who are already affected beyond the impairments that they already have. So what are the consequences of obesity stigma? So that there are the individual consequences to the person, but there are also the much bigger public health consequences with a disregard of sort of efforts for obesity prevention and further increase in health disparities and social inequalities. So all of this, the weight, stigma and discrimination at a population level is causing increased morbidity and mortality. So within the UK, I did a programme last year and there was very evident discrimination against people with obesity throughout the NHS, which is something that was really quite shocking. So how do we get around this? We need a public-centred, public health approach. We need to consider the complexity of obesity and the people's lived experiences. But most importantly, we need to support people affected by overweight and obesity and give them a voice so that they actually can speak and give that voice to politicians. We need to empower people to ask for the care that they need. And this is happening. So ECO Council is very powerful in helping people with overweight and obesity. Within the UK, we have patient groups, but these groups need to be supported and empowered for them to have a voice. Otherwise, they do get attacked by the media. So we really do need to reduce weight bias and obesity stigma if we are going to do anything to improve the care of the people that we look after with overweight and obesity. We really need to recognise it as a public health and society issue, and we, as healthcare professionals, really need to take up the mantle here and really take on the media and our politicians and really make sure that we make a difference to stop weight bias and discrimination. And we need policies to prevent stigma, and we need education, and action, rather than just doing nothing and coming and nothing changing. So we do need to work with the media. We need positive messages from our newspapers and from programmes. But having gone through my beginning of my talk about the benefits of a person-centred approach, I think we really do need to be adopting a person-centred approach for people with overweight and obesity in terms of prevention, treatment. But in order to do that, we really do need to tackle the weight bias, stigma and discrimination. And the people who are going to do that are the people in this room. So it's a bit of a call to action. Thank you for your attention.
Thank you so much also for reminding us for a person-centered approach and the call for action.